elaborate. The model is matching or exceeding, unfortunately, our most pessimistic scenario. So that means it's very concerning, and it therefore requires urgent and sustained focus at every level in the organisation. In terms of the EPI, particularly around influenza, it's already at levels that makes this an exceptional season, and it has not yet peaked. Plus there are still significant elements of both COVID and RSV, and obviously importantly COVID patients, even adjusted for age and complexity, tend to stay about twice as long in our hospitals, so that's a significant pressure. In terms of some of the operational data, again colleagues will elaborate, last week we saw as an example the highest ever recorded attendance and admission of patients over 75 years of age. So in summary, we are currently seeing unprecedented levels of demand on the overall health system. Briefly, just to talk about ED congestion itself, and again just to remind ourselves that ED congestion, the emergency department congestion, overcrowding, is a symptom of a wider system imbalance. It's not caused by or largely fixable within the emergency department, so it does need that overall system response, which is what we're bringing about. So in terms of outlook, for the next 10 to 12 weeks, our aim is to support our staff and work with all the stakeholders to protect patient safety and minimise negative impacts on patient experience. So this is very much a patient safety concern, and it's on that basis that we're moving forward. We want to be able to look back and say that everything that could have been done was done. Okay. If we look at the longer term solution, because no doubt there'll be questions about that, we know the longer term solution, as per government policy, Slán Care, is changing both the size and the shape of the health service. That means capacity investment, as indicated and supported by Minister and Government, where we're getting a lot of support already. That shift left in terms of moving to less complex parts of care, more self-care, more care at home, more community investment, and improvement in integrated care. In other words, better clinical pathways and better process flow. And we know, and it's evidence in the data that you'll see, that there is considerable variation in emergency department waiting time statistics across our individual 29 sites with emergency departments. We can't readily explain all of that variation by virtue of differences in demand and capacity of individual sites and their community teams. So that means there are significant systemic improvements that we need to make over the longer terms in terms of process effectiveness improvements, clinical pathway improvements, and whole system integrated working. But for now, we have the system we have, and for the next 10 to 12 weeks, we're focused on managing that system as best we can. So what are we doing about the current problems? We've briefed previously on our winter plan, which is part of our overall multi-year planning around emergency department and what we call unscheduled care pressures at winter time. Like every other country, this is a significant pressure this time of year, so we do plan for it. We plan for it on a multi-annual basis, and then in each year we have a specific winter plan. This year's plan, as we know, invested 160 million to support hospital avoidance, process flow within hospitals, and discharge from hospitals, minimising what we call, or seeking to minimise, delayed transfers of care. We've already intensified the operational management focus, what we call management grip. We've issued 10 essential actions out to all of the sites, and we're giving differentiated supports to those different sites who are more challenged by others. So that's what we have already been doing, and we briefed you on that before. In terms of additional escalations since we last spoke on this, given our concern about the developing situation, we stood up just before Christmas what we call our National Crisis Management Team, which I chair as CEO, and that brings an enhanced organisational focus so that the entire organisation is focused on mitigating this particular issue. We've also stood up site visits by myself and other members of the National Management Team so we can see firsthand what's being experienced on each site, provide some visible support, and assist where we can with problem solving. So we take away some of the issues and seek to resolve them nationally for the sites and for the hospital groups. We're also obviously re-examining all opportunities to get additional capacity onto the ground. So we have secured additional general practice clinic slots. So we'd expect that up to 8 hours of additional clinical slots can be done by GP general practices that sign up to that. Where we've secured an additional set of private hospital beds. So we currently have about 140 patients in those beds, and we're looking to expand that. That's separate to and on top of the National Treatment Purchase Fund beds, which are looking after the more normal elective care. We're also looking at every single set of community beds, be they public or private nursing home beds, to see what, if it's closed, can potentially be reopened, and what additional hours we can get from home support and from private diagnostics. Now, we're not inappropriately seeking to raise expectations. We're simply being clear that all of these options around capacity are being looked at and re-looked at to make sure there's no kind of stone left unturned. We're also clarifying and have clarified and updated clinical protocols, including in terms of infection prevention and control, to make sure they're playing the proper part in terms of balancing that kind of infection risk with the proper flow of patients, and also mitigating delays in ED clinical assessment. So this week, our Chief Clinical Officer issued a clarification, which is a change in that it ensures that if there's a significant risk of delay of assessment in EDs, that non-ED doctors can be called upon to assess patients in ED before the emergency department team has done so. And that's a change from the normal practice, and that is appropriate given the pressure we're under. We've also stepped up the already regular engagement with key stakeholders in terms of data sharing, so everyone's clear and is aware of what the current data is telling us, what the current problem is, and working with them on joint problem solving so we can support the hospitals and the community teams. Those engagements include with HICWA, with Nursing Homes Ireland, with the Private Hospital Association, staff associations, the College of General Practitioners, and home support organisations, and other key stakeholders. So this is an entire system response to what is a clear and present patient safety risk. This week, we've decided that we need to increase the level of weekend working, moving more towards what people may refer to as 7/7 care, so that we increase the amount of discharge from our hospitals at the weekend, including having additional on-site presence of senior clinical decision makers and other support staff to make that happen, again, across community and hospital. So that's a short-term measure. That's a measure for the next 2 to 3 weeks, particularly the next 2 weekends, and we'll review it. And measures like that are not sustainable. They are clearly exceptional measures at times of extreme pressure. But that is what's necessary at this stage. So that's what we're doing. Again, we're doing it on a patient safety basis, and we know our staff will respond, as they always do, positively to such things. So what can the general public do? What can we all do? Well, firstly, clearly we can all get vaccinated for COVID and for flu, particularly if we're members of vulnerable groups or we are around vulnerable people. If we're healthcare workers and we haven't yet got vaccinated, the advice is you really need to get vaccinated. And the advice is also that it's not too late to make a difference. Secondly, we should all be staying at home if generally unwell, and seek advice. The HSE's website and other trusted websites, including Under the Weather, which is part of the HSE website, or phone the pharmacist. So stay at home if generally unwell, seek advice. If you're still concerned, consider contacting your general practitioner or GP out of hours, albeit we recognise these services are also under pressure. The HSE's 14 local injury units are a further option. Details of their opening hours are on HSE.ie. And similar services are provided by private insurers, and we'd urge people to use all available options. Finally, of course, if people are concerned that someone may be critically unwell or very seriously unwell, always phone 999 for the ambulance service. We all want our emergency ambulance services and emergency department services to be available to help those who most need their life-saving expertise when they most need it. That is what our staff in these services will always seek to do. Therefore, though, the corollary of that is, in the best interest of patients, these services clearly operate on the basis of sickest patient first. They do not operate on the basis of first come, first served. So accordingly, we're asking that particularly over the next few weeks, everyone carefully considers whether attendance at an emergency department is both necessary and appropriate. Thank you. I'll pass over to my colleague.
Thank you, Stephen. So I won't go into too much detail around the EPI data. Dr. Cuddihy will do that a little later on, but it's important to note, just really gives the context of the level of respiratory illness that we are actually dealing with in terms of the operations right across the country. It's a very dominant feature in our EDs, and we've seen that ourselves out visiting over the last number of days, and in fact this morning as well. So, and that is resulting then in hospitalizations, and there you can see that we've had a significant rise since about the middle of December in our hospitalizations around COVID-19, and that has kind of plateaued. It's been a bit stubborn to come down, albeit it's coming down slightly in the last couple of days. Very much we're trying to get the message out to people through our communications processes that we need to maximise any alternative pathways we have to EDs. We have a number of those. Our Pathfinder services, which are a joint initiative by our hospitals and our ambulance service, are avoiding some of our patients coming to the ED and are assisting people to get home quicker. So we're trying to maximise all of those alternative pathways, including the local injury units. And as Stephen referred to, in addition to our own local injury units, there are other services from some of the private insurance providers as well. So people should consider all of those options as well. We should always be mindful of the vulnerable. And you know, when we're on public transport and other places where we can protect ourselves and protect others, and take whatever is the appropriate measure to do that. As Stephen said, our vaccination is key to not only protecting ourselves as citizens, but actually our health workers as well, to keep the capacity at what it's at, and then keeping ourselves well. So do everything we can to keep ourselves well. In terms of some of the operational data, we've had a very demanding period. We've seen a 15% increase over 2019, which would be the last, dare I say it, normal year that you'd be comparing to in terms of normal operations. So that's a significant change in terms of the number of people attending. The number of those people who are over 75, that reached a record level at just over 4,100 people over 75, and then in terms of admissions, you're much more likely to be admitted if you're over 75 and you show up at an ED. So again, a record number that we've had in terms of any records we hold, in terms of 2,200 of those over 75 patients were admitted. So as you can see, it's a significant increase. It's worth noting that in the last couple of days, while there's been an easing in terms of the number of people on trolleys or surge beds, that the attendances have actually remained at that high level. So that's, I suppose, indicative of the work that's going on across our EDs and in our community in terms of preventing, well, not so much preventing because the numbers are still the same, but certainly getting people into hospital beds, admitted or discharged to an alternative pathway. So there's a humongous effort going in there to achieve that. Our National Ambulance Service activity continues to run very high and increase. Those calls that you're looking at there are the high priority calls. It's not all of them. They do much more than 6,000 calls over a 3-week period, but those would be the life-threatening calls. So there's a significant number there. And you'll see there's a rising curve in terms of the number of calls we're trying to treat through alternative National Ambulance Service facilitated services like Pathfinder. So the more we build on those, they're embryonic to some degree, but they are preventing unnecessary conveyances to hospital. But it is extremely busy, as Stephen has alluded to earlier on. The way in which we're managing this across our system, it's a large, complex system that the health service is. And we have, at the local level, hospital and CHO teams who meet, multiple times per day, looking at every patient that they can facilitate getting to a more appropriate setting for themselves. Over that, then, we've got local integrated operation teams at the CHO and the hospital group level. We then have a national winter operations group that meets pretty much every day, certainly 3 times during the week and over the last number of weeks on weekend days. And the national crisis team that Stephen chairs oversees the entire effort to make sure that there is nothing that is not being addressed or is nothing that doesn't have the level of sign-off that it needs to get addressed. In terms of things that we have delivered, you've seen this before, I won't go into too much into that, but there's, there's 952 beds in acute beds delivered. We have 542 intermediate care beds that are contracted in additional to our own 365. There's 17, and up to October, which is the last report we have available on our home support hours, there are 17.5 million hours. We increased the number of home support hours for this year by 3 million hours this year. So we've put a lot in place, and we're putting more in place through the winter funding that we've received also. And our CITs, the community intervention teams, they're very effective in getting people home faster and getting people home from ED without being admitted, which is a huge benefit both to the health service but also more particularly to the patients themselves. The winter plan, kind of key initiatives in there our GPs are playing a huge role. The additional GP sessions that have been agreed are making a difference, and we'll have some data on that hopefully next week. So we'll come back to you on that. As I said, National Ambulance Service is engaging the private ambulance services, the voluntary ambulance services, and the community first response groups around the country are assisting in doing more than they would have normally done historically. GP access to diagnostics is preventing a large number of people from being referred into our acute hospitals, which is allowing that service to be available to doctors and other staff in the hospitals to get people treated and then discharged. Our home support, we're obviously challenged in home support in terms of being able to get enough numbers, but we are continuing to create more home support packages for people to get them home. And indeed, complex packages of care is an area that we've put specific funding in, where somebody has very, very significant needs in order to get them out of our acute hospitals and home to where they need to be. Our LIUs, our local injury units, as I said, are there also. That's them there. In addition to that, bear in mind there are a number of other units that the private health insurers operate as well. So if people have that covered, they should consider using that. There are additional other services that the insurers provide in relation to things like hospital in the home. Again, we're working with those services to ensure that their members are well informed of those capacities available to them. Those alternative pathways I spoke about, the GP, the local pharmacy is always, a good first protocol when feeling unwell. And self-care is an important element of any health system where it's appropriate. But as Stephen says, when someone is acutely ill, they shouldn't hesitate when they're acutely ill to access the emergency services, whether that's an ambulance or an emergency department. So our key actions, vaccination is obviously one of our key actions, and the more people it's not too late, I think is what our clinical colleagues will always say. It's not too late to get those vaccinations to protect both yourself and others. The increased access then to our local injury units, we've added a new one in Mullingar, we've extended hours in a number of them also. As I mentioned, we have additional contracted capacity around the National Ambulance Service. We've increased our staffing in our EDs. We've increased focus on patient pathways. So our medical assessment units, a priority for us to ensure that they don't get clogged up so that we can get medical patients in there and assessed rather than going through an ED assessment and then into a medical assessment following that. So, shortening that pathway is proving very beneficial. The increased private beds, so we have access, as Stephen said, to over 140 beds. We're increasing that all the time. We're in constant negotiations with the private sector to create that capacity. There's no one simple answer to that. There are different needs for private beds and different models. So we're making sure that all of those are accommodated. And then increased funding to assist discharges, whether that's a simple thing like an aids and appliance, whether that's a frame or some minor adjustments to a home, or indeed complex care packages which would require intensive care to somebody to enable them to stay at home. The increased GP sessions, as I said, is a huge benefit and very much welcomed. And then our increased access to private hospital beds and staffing over this very difficult time. And indeed, it has to be said, and I know Stephen has said it, we have to extend our appreciation to all of our staff who are really putting their shoulders to the wheel and putting the patient first at a very difficult time. So I won't go through that again, I'll just put that up there. I've said it all before. And what I'll do now is I'll pass to Eileen. Thank you.
Thanks very much, Joe. Good afternoon, everybody. So I'm just going to discuss a few points about the testing, contact tracing and the vaccination programme. So as all of you will be aware, the testing and contact tracing programme played a key role in breaking the transmission of infection and was key in relation to helping us emerge into a safer way in relation to living with COVID. When we look back on the last year, or the last 2.5 years of COVID-19 and the pandemic, we can see very clearly that our highest points in relation to testing were in Q4 2021 and Q1 2022. Since then, what is really, really positive is that the demand for testing and self-referral for PCRs has reduced by 97.6%. And you can see there the green bar chart, just a really, really low requirement. That's also in line with public health guidance. So the public health guidance is currently that if you're over 55 and you're symptomatic and you're fully boosted, you don't require self-referral for a PCR test. And if you're under 55 and you're otherwise fit and well, even if you're symptomatic, you don't require self-referral for a PCR test. There's a very small group of people, and that's set out in relation to the criteria. It includes healthcare workers, pregnant women, people with high-risk clinical conditions, people who are immunocompromised, and people living with persons who are immunocompromised. One of the key insights in relation to the people who are currently presenting for testing, the highest rates of testing are in the 35 to 44 age group. And each of the 2 decades, either they account for 18% of all positive cases at the minute, and each of the 2 decades either side of that are accounting for 15% of positive cases. So in total, the 4 decades between the ages of 25 and 64 are accounting for over 60% of the positive cases for COVID-19. So as I've mentioned, there's much less requirement for testing and tracing, and the public health guidance is that we move to a model managing COVID similar to other respiratory illnesses, and we are transitioning to a surveillance-led model. To date, we have 66 GPs that are part of that surveillance model, and over the next forthcoming weeks, we will continue transitioning our 29 large-scale testing centres. We have all but 4 of those transferred to smaller testing centres, and we will be transitioning and realigning the staff and redeploying staff to other areas who choose to work in those other areas. So in relation to the vaccination programme, which will probably be of more interest at this point in time, is our performance to date. And you can see from the graphs here that Ireland and our general population had a really keen interest and a big response to receiving their COVID-19 vaccinations. And Ireland is the top performing country in the EU, aligned with the ECDC data in relation to uptake of vaccination. We're also performing quite strongly in relation to uptake of booster 1 and booster 2. We're 5th in the EU in relation to uptake of both booster 1 and booster 2 vaccinations. What's of particular note is in relation to the uptake of booster 2, we're rating against other countries in relation to the 18 age group upwards. And as people will know, it's only last week that we've actually started offering booster 2 vaccinations to people over 18. And at present then we have a very small group of people eligible for their booster 3 vaccines, but we are rating top in the EU in relation to uptake of booster 3 vaccines. And it is all of that engagement with the vaccination programme that has got us to the point where we have managed to reduce critical care admissions and reduce the severity of illness for COVID. We are still seeing a high number of hospital admissions, so we are still seeing some severity of illness, but not the criticality of illness requiring the high level of critical care. This graph here just sets out where we are in relation to our 14-week programme since we've launched the bivalent vaccines. And just overall, there's been good uptake of the bivalent vaccines. Since on the week of the launch, numbers of people presenting increased about fourfold, and that has continued with small drops off over the October bank holiday weekend and also some lower uptake over the Christmas period. What is good is that since we launched the programme for the 18 to 49-year-olds, 70% of the people presenting are in that 18 to 49-year age group. So we're seeing good interest in that age group. This graph just gives a little bit more detailed of the breakdown of the various different age groups. But what I will just say by summary is that 77% of our population took up their booster 1 vaccine. 49% have taken up booster 2 and 38% have taken up booster 3. And then just a little bit more detail, we are seeing really good uptake by the over 65s, and that's quite important because the over 65s are most vulnerable in relation to severity of illness, and also that's the group that is having the highest number of hospitalisations. There's also good uptake across our residents in long-term care settings, but there's certainly more work to do with our healthcare workers, which we consider low uptake, but a lot of effort has been put into improving that uptake, and also persons who are categorised in the clinically vulnerable group. In particular, I just mentioned in relation to healthcare workers, and we're working through the National Director of Acute Hospitals and the National Director of Community Care to ensure every healthcare worker has an opportunity to get an appointment for their vaccine. A lot more clinics have been put on at hospital location because in the early days, a lot of healthcare workers were attending vaccination centres, but there is still more work to do, and we continue to encourage and ensure healthcare workers across all services have every opportunity to get their vaccine appointments. We're comparing data across hospital groups and across CHOs and offering every support and keen to help where it's most needed. This data just looks at the overall uptake for residents in long-term care settings. And for those of you who might have picked up the figure on one of my earlier slides, we've split the data by residents in long-term care settings for persons over 65 years and persons under 65 years. So the over 65 years is showing a stronger uptake than the overall uptake of residents in long-term care settings. And there's continued visits by mobile teams to long-term care settings to ensure that every resident has an opportunity to get their COVID-19 vaccine and also their flu vaccine, as protection of that group is critically important due to their vulnerabilities. So what most people will be aware in relation to the most recent news is the availability of COVID-19 bivalent vaccines for persons 18 to 49 years. We've encouraged people to come to the central vaccination clinics because we're aware that our general practitioners and also our pharmacies are quite busy at the minute. But the bivalent vaccines for that age group are available across all 3 locations. Anybody who requires to book, it's very simple. You can go online and just book on www.hse.ie. And while the centres are busier now than they were, there are still plenty of appointments available. In addition to persons 18 to 49 years, NIAC have approved booster vaccines for 2 additional cohorts of people. And one is the children in the 5 to 11 age group who are immunocompromised. And these are a particularly vulnerable group of children. They comprise of approximately 660 children. They've already received their primary vaccines. A small number have received an additional dose due to their immunocompromised status. And they have also had opportunity to receive a booster vaccine since September. But at that point in time, the bivalent vaccines weren't available for that age category. So now the bivalent vaccines are available for immunocompromised children aged 5 to 11. And the second group that vaccines are available for, vaccines are available for are the children 6 months to 4 years. And we are working with the Department of Health in relation to the timing of the development of a statutory instrument, and the National Immunisation Office will be developing the medicines management protocol, and we ourselves will be working with our experts in relation to consent for this age group. And once we have all of those elements aligned, we'll be agreeing a date for commencement of vaccination for the children 6 months to 4 years. So just on a closing point, people will have seen this slide at the earlier point, but once we add an additional 1.5 million people in the ages of 18 to 49 to our booster 2 vaccination, it changes our denominator data and it automatically appears that the uptake of booster 2 vaccine is low. You'll remember I highlighted it was 49%, and once we add that additional 1.4 million people, it reduces our overall uptake to 30%. But given that we've just started that programme, I expect that to change significantly over forthcoming weeks. So in line with what the CEO has advised and my colleague Joe in operations, it's really important that we continue to encourage people to get their booster vaccinations. Immunity wanes over time. We're looking at all of the international evidence, and we see that vaccination is important for all age groups, and there is still some work to do when we look at where the infections, the groups that have highest positivity at the minute, and when we look at hospitalisations, vaccination is still a key element in maintaining the safety across society and helping us emerge in totality from the pandemic. So thank you very much.
Good afternoon, everybody, and I would like to update you on the latest epidemiology in relation to winter virus notifications of cases and hospitalisation. And the first thing I'd like to say is just that in week 51, which is week just gone ending 31st of December, each year we see an artificial decrease in the number of cases and hospitalisations. This happens internationally, and it's related to the changes in testing, surveillance and reporting that happen in that week with 2 public holidays, and also changes around the Christmas period in health-seeking behaviour. So in general, the trend that we've seen in week 50 and 51 is more reliable than taking into account week 52 at this point. But next week we'll have data for those 4 weeks, which will give us a more accurate picture of the current trend. So first of all, looking at the COVID data, and we can see that over those weeks 50, 51, we've been seeing increased cases and hospitalisations, and then that artificial decrease in week 52 that I spoke of. Likewise, with the COVID outbreaks, we have been seeing significant numbers of outbreaks in hospitals and nursing homes, which is generally what we've seen all through the COVID pandemic in relation to a correlation between community activity of disease and outbreaks in healthcare settings. This slide for COVID shows the 7-day incidence rate per 100,000 population, and really, I suppose, just to note that the over 65s and those who are 45 to 64 have the highest incidence rate per 100,000 population of COVID at the moment. Geographically, again, it's the incidence per 100,000 population, and it's showing higher incidence in Waterford, Kilkenny and Carlow, but just the caveat here is that we're looking at small numbers in comparative terms and per 100,000 population, so it's difficult to make reliable assumptions from this. The outbreaks in healthcare settings, again, in hospitals and nursing homes, we've seen this sustained increase in COVID outbreaks over the past 5 to 6 weeks. Just a word in relation to the COVID situation in China. The number of COVID-19 cases has reached a record high in mainland China, peaking on the 2nd of December. There continues to be a lack of reliable data on COVID cases, hospital admissions, deaths, as well as intensive care unit capacity and occupancy in China. But the high levels of SARS-CoV-2 infections and increased pressure on healthcare services there are expected in the coming weeks, or expected to continue, due to low population immunity and the relaxation recently of the non-pharmaceutical measures. But just to note that no new variant has been detected in China according to the available reports. The variants that are circulating in China are already circulating in the EU, and as such are not challenging for the immune response of EU EEA citizens. In addition, EU EEA citizens have relatively high immunity and vaccination levels. So given the higher population immunity, as well as the prior emergence and subsequent replacements of variants currently circulating in China by other Omicron sublineages in the EU-EA, this surge of cases in China is not expected to impact on COVID-19 epidemiological situation in EU-EA countries. And this is reported in a recent risk assessment by the European Centre for Disease Control and Prevention. So secondly, moving on to the influenza epidemiology, and you've seen this graph in an earlier slide. To note, in terms of the cases notified of influenza this year, we've seen an early influenza season beginning in week 45, where the influenza-like illness rate exceeded the baseline threshold. That would have been a week ending the 12th of November. In addition, we've seen a very steep, rapid increase in the notification rate of cases over a short period of time, and consequent increase in hospitalizations. The artifact that we've seen in week 52, the week just gone, you can see here again, but if you look at the previous influenza seasons, that little artifact was seen during that week also. So in terms of the question around the length of the influenza season and when it's likely to peak, it's difficult to predict, but on average, the influenza seasons in the past have lasted an average of 11 weeks, but with a wide range, sometimes over 20 weeks, which would take the season into April or May. And the peak is usually in the midpoint of the season. The hospitalized cases of influenza, the highest rates are in the under 4s and the over 65s, both for cases and for hospitalizations. And this brings us to influenza vaccination uptake by age group. And the uptake in the over 65s is at about 74%. But in the 2 to 17-year-old age group, influenza vaccine uptake is 12.7%. In the 18 to 49-year-olds, it's 9.3%. And in the 50 to 64-year-olds, 24%. So fortunately, relatively higher uptake in the over 65s, who are one of the most vulnerable groups. RSV, respiratory syncytial virus, again, a very early start to the RSV season. You can see here that RSV cases and hospitalizations have been declining in recent weeks, but not infrequently in previous seasons we can see a double peak of RSV, and that can sometimes happen after children return to school. So we'll be watching over the coming weeks the trend in these RSV case notifications. Again, the highest rate of RSV hospitalized cases is in those under 1, because in that age group, the virus can cause bronchiolitis or pneumonia, particularly in children with underlying conditions or who are immunocompromised. So I suppose just to note that in the past 2 winter seasons, we've had COVID-19, but little or no influenza, RSV, or other respiratory viruses. In the seasons prior to COVID years, we had RSV and influenza. In this current season, we have all 3. And we are seeing across Europe, in the UK and beyond, and from reports of ECDC and WHO, a severe impact on the wider health systems across these countries related to this somewhat unique epidemiological picture. Just a word about invasive group A, streptococcal. In terms of the pediatric cases particularly, well, this slide shows over the past few years the numbers of cases notified overall and the number of pediatric cases. And you can see that in 2022 there were 100 cases overall, compared with 130 and 136 in the years pre-COVID. So not dissimilar. Likewise, the percentage of paediatric cases was 34% in 2022 and a very similar percentage in those pre-COVID years. But unlike previous years, this year the surge in invasive group A strep cases occurred in December. You can see on the bar chart here on the right. In terms of the mortality from invasive group A strep in all age groups in 2022, unfortunately there have been 12 deaths and 4 of which were in children. And you can see the comparative figures for the previous years. The trend graph on the right really just shows in graphic form this surge in IGAS cases in December, but ultimately reaching the same level as in the pre-COVID years. So the key messages, I suppose, have been mentioned earlier presentations, but the preventive measures haven't changed. The physical distancing, hand washing, respiratory etiquette, ventilation, staying at home if from school or work if someone has symptoms, and that's staying at home until the symptoms have resolved for 48 hours. Vaccinations for flu and COVID, certainly looking at the uncertainty of the duration of this flu and COVID season, it's certainly not too late to avail of flu and COVID vaccinations. And finally, the advice, particularly that's available on undertheweather.ie in relation to managing symptoms of illness at home wherever possible. Thank you.
Thank you very much, John. Now we'll take questions. If you could identify who you are and the media organisation you're from, please. That'd be great. Thank you.
Hi, I'm Louise Byrne from the Irish Mirror. Happy New Year. Stephen, you said that you're speaking about decision makers being in hospitals over the weekend and things like this, and you said it's not sustainable in the long term. Would it not be, in everyone's favour to have people in every weekend, all hours of the day, so that when NCHDs are going around and they're making their rounds, that people can be discharged then and there? Would that not help get more people off trolleys and get people into bed sooner? And then secondly, I guess we've seen the numbers on trolleys come down drastically in the last 2 days. They've come down by about 300. Is there any reason why it's come down so rapidly over the last couple of days, or is it just that it's kind of all shoulders to the wheel?
So the second one first. So firstly, it is all shoulders to the wheel, and the level of discharges has been strong. But we also should say typically the worst days of the week are at the start of the week, and it improves as you go towards the end of the week. So, but still, we are seeing exceptional efforts being made and exceptional results. On the bigger question, so in the short term, given the way the system is set up, we can only look at the next, let's say, 10, 12 weeks. So the way we're currently set up, and remember that the service is a 24/7 service, but it doesn't operate at the same level all 7 of those days. That's just the way it's established. So for these next few weekends, we are going to increase the level of both decision makers, consultants particularly, at weekends, and also the support staff in hospitals in the community. Should that be the way forever going forward? It's a debatable question. In effect, how would you put it? When the system is working normally, and depending on overall capacity and process, hospital sites that do well will actually compensate by trying to get enough discharges on the 5 days during the week when most occur to compensate for the admissions at the weekend. But over time, hospital systems are more likely to move towards, at least going towards Saturday work, particularly where that's necessary. So, but in the short term, what I'm saying is it's not sustainable given the model we currently have. It's a lever you pull when you're in extremis, and that's why we're pulling it, because of the patient safety risks, and our staff, as they always do, will respond positively. But there's only so much you can sustain that for, because the system is built to operate predominantly 5/7 in terms of its highest levels of activity, even though it is a 24/7 service, if that makes sense.
Chambers from Virgin Media News. Just in terms of the situation which you're now seeing in emergency departments, obviously there's been a high number of high-profile cases in the media of people waiting in emergency departments, whether they be on chairs or on trolleys for 40, 50, 57 hours reported by one person again today. Now, obviously, you're going to tell me that you can't comment on individual cases, but when these are so widespread, what exactly do you tell patients and their families who are going through this and they have to suffer the indignity of that or having their conversations overheard by other patients beside them in trolleys and chairs? That's surely not good enough as a situation. And what are you telling them then about the situation that they find themselves in and what you're going to do to make it better?
So we accept, Richard, it's not good enough. It's not what we want. It's not what the staff try every day to make sure doesn't happen. And what we ask the patients to do is to accept often our apologies, and that's, and we seek to make the patients as comfortable as possible. Okay. Now the key issue obviously is it is sickest patients first. So we are trying to get to the sickest patients, and other patients will wait longer. Now there are patients waiting for admission. You can see them if you visit hospitals and AD departments, as we have been, and you have to have a very hard heart not to feel a kind of a sense of loss at looking at some of that. So we know that's not what is good for the patients. It's not what the staff are trying to do. And at the moment, the best we can do is ask people to bear with us, and for those that can consider other options, to think about options other than the AD department. But it's not what anybody wants, and it's not viewed as acceptable by anyone, in fairness.
Obviously, you've mentioned here as well, and clinicians are also saying that there's obviously huge patient safety risk as a result of all of this. Has there been any deaths identified which have been associated with the delays which we've seen so far?
A couple of things. As you said, I'm not going to comment on individual cases. As serious events adverse events are reported, they are fully investigated and lessons have to be learned. But it's fair to say, okay, that every health system in the world has avoidable and preventable deaths and harm. And Ireland is no different in that context. And we know that over-congestion in EDs increases the risk of harm to patients, and that's a fact. So that is why we're seeking to take all these measures to mitigate that as much as possible. The individual cases then, we don't want to comment on individually, but they will be investigated, and where lessons can be learned, that's the aim of that.
Just in terms of, obviously, you're saying and you're identifying all the ways you're trying to make things better now, but obviously this is a situation which we have seen many, many years now, concurrently going back before COVID and whatnot. The situation which the doctors, the nurses, people in the HSE say is obviously inpatient beds, that we simply don't have enough of them. We haven't had enough of them for many, many years now. Why can't the HSE simply come out and say we're begging for extra beds here at this point, that we aren't going to have winters where we don't have such serious pressure in our emergency departments until we increase the number of beds, because we are still at a very low level in terms of international comparison?
A couple of things. The first thing, obviously, is none of that helps anybody in the next 10 to 12 weeks. So we're focused on managing the system we have today. Okay. Secondly, yes, and government is very clear, and government policy is very clear, and government has supported the increase in acute inpatient beds. We've put in more acute inpatient beds in the last 3 years than in any period before that. And I've checked back over the last 40 years. Okay. Yes, bed numbers did fall. Now, are bed numbers the only solution? No, they're not. Okay. They're an essential part of fixing this, and we will seek to bring forward next year a kind of a 3-year plan to move towards a kind of a more longer term solution, which is effectively set out in government policy and Sláinte Care. But it's not just about inpatient beds. It is also about capacity elsewhere in the system, which again government is supporting investment in, including in community care. But more than that, it's also as well about making sure the processes and the integration of process makes best use of all that capacity. So all those things come together. So there's no one part of it. And as I said, the investment over the last 3 years, including specifically in acute hospital beds, has been greater than in any individual period of similar length going back over the last 30 years. Thanks.
Mairead Cleary here from News Talk. Just firstly, on the senior doctors being available in the hospitals at the weekends for the next 1 or 2 weekends, is there any kind of financial gain for those doctors who are working beyond their contracted hours? We heard from the Consultants Association earlier that they're just already at their wits' end and they're already burnt out. The other question I have is about delayed discharges. Is there any kind of ballpark figure on how many beds in the system are being taken up, per se, by delayed discharges? And are there going to be more, nursing home beds or community beds available to move those patients out to?
So on the what we call delayed transfers of care first, that number is reported every day. Today I think it was down at 525. 525. So it has come down over the last couple of days. It was up over 600 a week ago. One of the efforts we're making is to see how many, if any, of our own or private nursing home community beds, private nursing home and public nursing home beds have closed recently or could be reopened. And we're also obviously working with HICWA to see whether we can ensure we can get patients appropriately and safely from the hospitals into those nursing home beds. So yes, we are trying to make sure every individual, and literally we have a team who are effectively going around all of our 9 community healthcare organisations looking at exactly what community beds are there and what are occupied and what can be occupied. So we're working on that. Remind me the first part of your question.
The consultants already, if any financial benefit?
Yeah, in fairness, some consultants already do work at weekends. There is already provision for what we call structured on-site overtime as a payment mechanism. I don't believe, in fairness with both consultants, the money is the issue. As you said, some of them are already working significant time and putting in discretionary effort, and that's understood. The issue here is, given the extreme situation and the patient safety situation, we know all of our clinical staff and our other staff, including our consultants, because they always have done, will respond, because ultimately their real focus, as ours is around the patients and their safety.
Adam Higgins from the Irish Sun. John, can I just ask, Stephen mentioned that the flu season hasn't peaked yet, and you mentioned yourself that it usually peaks in the middle of the flu season. Have you any indication of where we are in the flu season and when you expect that peak to come? And then separately for Stephen, Richard mentioned some of the horror stories we've heard about people waiting up to 50 hours on a chair for a bed. Are there any figures on the average waiting time that people are waiting in EDs, and what's the longest you've heard yourself?
The duration of the flu season and when it's likely to peak, as I mentioned, the average is 11 weeks of season, but it can be over 20 weeks. And this winter season, it's particularly difficult to model the trajectory of influenza and COVID, because this season is unlike any season that we've seen before, for the reasons I mentioned earlier, that we've now got COVID in addition to flu, RSV and the other winter viruses. But looking at the trajectory of cases notified over the past number of weeks, not just looking at the recent weeks, and comparing that with the pattern in previous influenza seasons, I think it's likely that we will see a significant and sustained increase week on week in cases notified of influenza, and as a consequence then hospitalizations over at least the next 3 to 4 weeks.
Joe will give some of the specific details about the averages, but our aim, obviously, the gold standard, obviously, for us is less than 6 hours. There's a kind of a backstop at 9 hours and then 24 hours. And we know we're not hitting those targets, and we know that our level of achieving those targets, particularly for admitted patients, those who do need to get admitted, has increased and is worsening. Okay, and I have heard, let's just say, numbers that are in many days more than you'd like to hear. So again, that's not acceptable. That's not the kind of care our staff want to provide or we want to provide. Unfortunately, it is a reality, and in some cases this will get somewhat worse potentially before it gets better. Our aim is to do everything we can do to avoid that. But just in terms of some of the average numbers, Joe, do you have?
Yeah, so the total average would be around about, for everybody, about 8.3 hours would be the average. However, as Stephen would have mentioned, admitted patients, so if you just look at them alone, as opposed to people just visit the ED and go home, they tend to stay longer. So their average is up around 13.8 hours. And that's the area that we're trying to focus on to reduce, because that's where most of the harm happens. So we would go after that in the first instance. The non-admits would be significantly less than the 8.3. So it makes sense that if you're being admitted, you will be getting more tests and things like that. So you tend to wait longer in the ED. So that's why that average is higher.
Hello, Niamh Griffin with the Irish Examiner. Some of the hospitals like Waterford, Beaumont and Tallaght to a certain extent have turned around huge trolley issues in the last year, this winter and last winter. How are you getting that learning from those hospitals to the other hospitals? Why can't it be done everywhere?
As I said, Niamh, there is variation in that performance across sites that you can't explain readily, at least by saying this hospital, a Beaumont or a Waterford, has less challenges than that hospital. So that's acknowledged. So we are sharing that learning. We've effectively put some of the key meshes as to what they've done into some of our let's just say, protocols and our 10 essential actions. And as recently as, I think it was last Monday week, we had a kind of a learning day where we brought representatives from Waterford to meet a wider gathering of hospitals. So we accept that variation is there. Now, the fact that it's there is not unusual across hospital systems. There's always a level of variation. It doesn't mean it's a simple thing to fix, but it's back to what I was saying there. You can, while you do need additional investment, absolutely, there is a process piece that can make improvements. And it's those improvements, particularly in the short term, that we're chasing in order to mitigate what is a fairly serious patient safety issue. So we are holding up the likes of Beaumont and Tullamore and Waterford in particular. Waterford hasn't had a trolley. I still think it hasn't had a trolley in 1,000 days. Now, was there some investment in additional capacity in Waterford? Yes, there was. Did they use that as a catalyst to make significant changes? Yes, they did. Are they the only hospital that got investments in additional beds over the last 3 years? Of course they're not. And have all hospitals been able to achieve the same results? No. So while it isn't a simplistic thing, we are working with groups and with hospitals to see how best they can improve, because we know there's always room for improvement there, particularly when it comes down to trying to mitigate these types of issues.
Thank you. And just on the cancellations, some of the hospitals said this week that they're cancelling electives. Do we have a number or an estimate for how many people have missed out on electives this week?
Firstly, we would have, as hospitals know and groups know, and we would have advised before Christmas, the aim was to schedule as little as possible in the first few weeks in January in any event. And that's what a lot of hospitals did. And whenever we do have to cancel, and there will be levels of cancellations, what we have to remember, people often refer to as elective. What we will always prioritise is what we call urgent, time-sensitive work, often cancer or similar type work. But there will be, and there has been, a level of electives cancellations. I don't know if we have any figures, John, possibly.
We don't have any numbers yet, but we are working on getting, polling around. We don't have an automated way of doing that, so we have to poll around the system. So next week we'll have better numbers for that.
We'll make that available, but it will be a reality. We are looking to minimise it, and we will also always seek to protect the urgent, time-sensitive work as much as possible.
And sorry, can I just ask one quick one? Say it's a yes, no. Has the HSE's board met since the crisis was declared on Christmas Eve to analyse what's been done?
The HSE's board has been fully updated in, I think, 2 separate briefings, and it'll meet shortly for a special meeting on 2 topics, including this. But to be clear, they've been very significantly updated, and the chair has been briefed on a regular basis as well.
Paul Cullen from the Irish Times. The Minister's been asking consultants to come in weekends at night, and I don't think he's been waving his chequebook around. Can you just clarify your earlier answer there? Are you looking for consultants to come in, and are you offering them days in lieu or overtime or whatever in return for doing that?
So yes, we are looking for a range of staff, including consultants, to come in at the weekends. There are arrangements already in place to cover things like structured overtime. And separately, we're looking at kind of overall HR, IR flexibilities and what can be put in place.
Just dealing with the consultants first, will they be paid overtime or days in lieu for coming in?
They can already be paid. If they come in, there's a structured overtime payment arrangement already. And if somebody wants to, it's not a new thing, it's a standard thing. If they want to replace that with toil, that's a local discussion. At least that's the detail I'm aware of.
Yeah.
I don't think that's the big motivator for most of our consultants. So we'd obviously prefer if the story wasn't built around will consultants come in or not come in, depending on the money. That's kind of probably unfair to the consultant body.
Yeah, because consultants have obviously taken umbrage with the Minister's comments, and a lot of them have pointed out that, obviously, as you'd expect them, that they're around, but they say the other services are not around, the diagnostics, the support staff, even the porters. I mean, this argument about a 5-7 hospital has been going around for years and years, and here we are talking about it in the middle of a crisis.
Talking about it, Paul, in fairness, one of your colleagues asked the more longer term question, should we not operate that all the time? So the consultants are right. In order for them to come in and be as effective as possible, in some sites we need more staff, diagnostic staff, other support staff, and all of those staff are also being asked to come in, particularly for the next couple of weekends, as is the community, and to be available. So there is a reasonable point there that consultants aren't sole traders, they have to have the support around them. The intention is to have as much of that support around them as is feasible over the next couple of weekends.
And you're saying ask?
Yeah.
It's not a directive.
No, it is mandated. We have issued a kind of a national mandate to all the staff that's our requirement. But again, given the type of staff we have, including our consultant staff, they respond to what they see in front of them as clear issues for their patients. And they always have done, and we want to acknowledge and thank them for that.
Just one other question there. I'm sure you must be made aware, Joe or Stephen, of the more extreme cases. So what you mentioned the average weight, Joe, but what has been the range of weights, long weights that you've been informed of over the last week? We heard on the media from 40, 57 hours. Are there longer ones than that again?
Not that I'm aware of, than the ones that have been reported.
Well,
no.
Were you aware of that one?
I was aware of that one.
You were?
I'm aware of it since it was reported, yes.
Since reported on the media or through your own channel? Do you have any knowledge of what the patients are going through at the
We do.
extreme end?
We monitor that on a daily basis. We monitor 24-hour breaches as we would understand it.
What are the figures on that? You know, how many 24-hour plus breaches have there been this year or in the last week?
I can give you that number if you just bear with me, but yeah, I'll just need to dig it out of here. But yeah, so we would record that regularly. In fact, we record it every week and we report it every week internally. So I can get you that number, just bear with me now. The 24-hour breaches year-to-date cumulative would be 67,000.
67,000? In 5 days? In what time for the year?
In a year, in a full year.
Oh. 2022.
In a full year.
2022.
In 2022.
And the last week?
I don't have that to hand. I'll have to get that to you.
Hi, Rowan Smith, Irish Daily Mail. You said during the briefing that there was 140 private hospital beds being utilised at the moment. Just asking why not more. The Minister asked us to be more ambitious about it, and we all saw the deal we had during COVID about how much we could take the capacity of the private hospitals.
So just on that, so we are looking to take more. So first of all, at the moment, as of yesterday, it was 145 beds, of which we had 140 actual heads on the bed. In response to this particular issue, separately, the National Treatment Purchase Fund will have patients going through the private hospitals. Now, private hospitals have over 2,200 beds. However, about 600 of those are day beds, so they're not of use for this. So there's about 1,600 beds that are of use, and about 150 of those are on particular sites where what they do certainly wouldn't be appropriate for what we're looking for. So we're currently therefore taking about 10% of their capacity, and we're actively engaged with them to see across 3 headings: urgent, time sensitive, unscheduled medical patients, ED patients, and if necessary transitional care, how many in total of their beds. And we will take every one of their beds that they're able to take our patients for. So those conversations are going on as we speak. And our aim is, it's not constrained financially, the aim is to do what's necessary. And again, we've no doubt the private hospital colleagues will step up to the plate.
Dr. Mike Malloy, who's an emergency consultant down in Wexford, was on the radio today saying that with consultants being asked to put the shoulder to the wheel more and more without things actually getting better, people might be considering retirement rather than working harder. What are your concerns about keeping emergency medical consultants, considering the amount of stuff they've had to go through the past few years and things not looking to get any better?
Yeah, I think that's always a concern for retention of staff right across the health service. During COVID, our service and other services was under huge pressure, and therefore that kind of retention issue is a big issue, not just in consultant grades. In terms of our ED colleagues, again, if you remember what I said at the start, the problems we're experiencing are a symptom that kind of arrives in the emergency department, but it's not fixable or caused in the emergency department. So all of the measures around trying to level the load across the whole hospital at weekend working are actually designed to support the ED consultants and ED staff by making sure the problem is shared by the whole system, including the rest of the hospital and the community. So, and separate to that, we have and continue to invest in additional ED consultants to make their rosters, let's say, more manageable. 50 extra have been approved in this winter plan, 20 of those are in place as locums already. So we recognise the risk across a variety of grades, but we are seeking to attend to it, Joe.
Yeah, just on Paul's question, just to give some context to that, Paul, I think it's important. Yes, last week we had 1,887 people that breached 24 hours last week. Bear in mind there were 27,000 attendances. So, you know, each one of those people that breached the 24 hours is of concern to us, and it's our objective to get that down to zero as quick a time as we can. But just to bear in mind that it is a big number. It certainly sounds big, but the context of it needs to be fully understood as well.